In pathology, some of the biggest clues can come in the simplest colors, like a red patch versus a white patch in a patient's mouth. Today, we're going to walk the pathologist's path, from that very first clinical glance all the way to a final diagnosis, to really understand why these colors signal such dramatically different risks.
So, let's start with a scenario you're absolutely going to see. A patient comes in with a white patch in their mouth that just won't go away. It's a pretty common sight, but it immediately triggers a critical question. What do we do next? What is this diagnostic journey we're about to start?
We are literally going to follow that biopsy from the clinic straight to the lab. The goal here is to think like a pathologist, to connect that visual clue, the white patch, to the microscopic story that the cells are telling us under the scope. Okay, so our investigation starts by identifying the two main suspects, and we base it on what they look like. We've got the white patch, which we call leukoplakia, and its less common but frankly more ominous counterpart, the red patch, called erythroplakia.
First up, leukoplakia. Now, the number one rule you have to remember here is that this is a diagnosis of exclusion. The WHO defines it as a white plaque you can't scrape off, but, and this is key, you can only call it that after you've ruled out everything else, things like a fungal infection or maybe just some irritation. If nothing else fits, then you're looking at leukoplakia.
And on the other side of the coin, we have erythroplasia. This one shows up as a red, often velvety patch. And just like leukoplasia, it's a diagnosis you make after ruling out other causes for a red lesion, like inflammation. That color difference? That's our first huge clue that something very, very different is happening at the cellular level.
All right, so we've moved from the clinic to the lab. The biopsy is in, and now it's time for the histology. This is where the real detective work begins. We're looking under the microscope to see what this lesion's true nature is, and, most importantly, its potential to turn into something much worse. So why is leukoplakia white in the first place? Well, the histology tells us exactly why. Microscopically, we usually see a buildup of tissue. It's a thickening of the outer, protective layers of the epithelium, probably in response to some kind of chronic irritation. The tissue is essentially building up armor to protect itself. So if we zoom in, we can see some specific features. There's often hyperkeratosis, that's just a thickening of that outer keratin layer, and acanthosis, which is a thickening of the whole epithelium. But here is the really critical part. Only about 10% of these cases will actually show dysplasia, those disorganized precancerous cell changes that we're really worried about. Erythroplakia, though, tells a completely opposite story. That red color is a major warning sign. Under the microscope, instead of a thick, protective layer, we find a thinned-out, atrophic, and really vulnerable epithelium. The blood vessels underneath are much closer to the surface, and that's what gives it that bright red look. The features we see here are, frankly, alarming. We're talking a thinned-out epithelium, a total loss of that protective keratin layer, and a ton of inflammation. And if there's one thing you take away today, it's this. A biopsy of erythroplakia almost always reveals high-grade dysplasia or even carcinoma in situ, meaning the cancerous changes are there, they just haven't invaded deeper yet. So, let's just put them side by side because it's a simple but really powerful contrast. On one hand, leukoplakia is a story of thickening, of fortification. On the other hand, erythroplakia is a story of thinning and breakdown. They are complete histological opposites, and that difference translates directly to their vastly different levels of risk. Okay, so let's pull all of this together. We're going to compare these two lesions directly, looking at everything from what they look like in the mouth to what they really mean for the patient's future.
This table really just lays out the stark difference in risk. For erythroplakia, the risk is incredibly high. We're talking around 90% of biopsies show serious changes. That means an urgent biopsy is mandatory, every single time. Leukoplakia, on the other hand, has a more variable risk. A biopsy is still the way to go, but it becomes absolutely critical if the lesion won't go away, looks irregular, or is in a known high-risk spot.
And this brings us to the ultimate question, right? Why does this distinction matter so much? Well, it all comes down to the risk of malignant transformation. Understanding this difference is absolutely fundamental to managing patients correctly and predicting their outcomes.
See, with leukoplakia, the risk isn't just one simple number. It's a whole spectrum. And one of the biggest clues a pathologist or clinician uses to figure out that risk is where the lesion is located. Not all white patches are created equal. And here's the data that proves it. A white patch on the floor of the mouth has a staggering 43% chance of already having dysplasia or cancer.
Now compare that to the palate, which is down at 19%. This is classic high-yield info for exams. You absolutely have to know these anatomical high-risk zones.
And what about erythroplakia? Well, that number pretty much says it all. About 90%. Let that sink in. That's the percentage of these red lesions that will show severe dysplasia or carcinoma in situ on biopsy. This isn't a variable risk, it's practically a certainty. A red patch is a red flag. Period.
All right, here's a super simple mnemonic to lock this in your brain. E is for emergency. Erythroplakia demands your immediate attention. L is for lower risk. Leukoplakia's potential is lower, sure, but that risk is still very real. You have to respect it, especially when it's in a high-risk site or has that speckled, bumpy look.
Okay, let's bring it all home. How do you take all this knowledge and structure it into a perfect, concise answer for your oral exams? I've got a blueprint for you.
Look, your professor is almost certainly going to ask you about these 3 core areas. They want to see that you can define the clinical terms, that you can explain the microscopic pathology underneath, and, most importantly, that you can connect that pathology to clinical risk and decision-making.
Here's how you deliver a killer 2-minute summary. 1. Start with the clinical definitions, emphasizing their diagnoses of exclusion. 2. Move to the key histological contrast, thick versus thin. 3. Conclude with the punchline, the huge difference in malignant potential and how that dictates what you do next. That structure shows clear, logical, diagnostic thinking.
And hey, if you want a bonus point to really impress your examiners, remember proliferative verrucous leukoplakia, or PVL. This is a special, high-risk variant. It's persistent, it spreads, and it has a crazy high rate of transforming into cancer. We're talking 40 to 70%. It's a very aggressive form that needs to be watched like a hawk.
So, we'll leave you with this thought. We started with color, red versus white. But the real decider of a patient's future is dysplasia. So the final question isn't really about color at all. It's this: once you see those disorganized cells under the microscope, how do you completely reframe the conversation from "what is this lesion" to "what does this mean for this person's life"? Answering that is the very heart of being a pathologist.